computer. Perfect, lovely stuff, guys. I will just share my screen as well. Cool. Can everyone see that okay? Yeah, thumbs up. Cool. Lovely stuff, guys. So yeah, CPD tonight is going to be a little bit different. You won't have to listen to the Australian tones of Dan for the evening. You get me instead. And what we're going to do is we're going to talk through the roadmap, the FCP roadmap. So I'm sure most of you have heard of the roadmap now. It's essentially something that Health Education England have introduced for all FCPs and APPs to go through over the next year or so, to essentially ensure that we're up to a certain standard. I know some of you may have had some communication with Sam, who's down in Hampshire, about some of the bits that you've done already. But what we've decided to do, we've decided to split it into the two areas, so London and Hampshire. So in terms of the roadmap now, it will be organised by the clinical lead of your area. So myself for Wandsworth Lambeth, Chris for Croydon, Lockie for Merton and Sutton, and then Sue Ellen for up in North London. There's still a lot of unknowns around the roadmap. There's still a lot to learn. So I think some of this will change, and there's still some bits on here that are a little bit of grey areas. So there may be some updates to come, but this is what we know now. And what we wanted to do was just spell out a bit of a clear plan for you guys, so you had an idea of what we were going to be doing moving forwards, and kind of the timelines that we wanted to work with. Individual questions about the roadmap, probably best to wait till just ask your clinical lead rather than asking on here. But if there's general questions about the timeline and things, we're more than happy to ask. As I say, me and Chris, this is kind of working in progress, so there may be a few answers that we'll have to come back to. So first of all, what is the roadmap? So I took this directly from the roadmap document. So it's a supportive document which provides a clear education pathway to advance practice for those wishing to pursue a career in primary care. So I think a key point that we need to make about the roadmap is, yes, it is a bit of work. Yes, there is work, but it is CPD for you guys. It is that career progression. We don't want to see this roadmap as a kind of an arduous, oh, we've got to do this, we've got to do that. This is if we are going to be progressing forward on the roadmap and in our careers as well. So it'd be a good opportunity to kind of progress your career in certain ways and work with the clinical leads. And the other thing it says is ensuring all FCPs and APPs have the correct clinical knowledge and skills to be working in the unique setting of primary care. As we all know, as FCPs, we are working in a new and unique version of physio. We're seeing patients that we probably wouldn't see in any other kind of physio departments in terms of some of the certain presentations. And really health education and us as Surrey Physio, we need to know that everyone is up to a level where they're not going to miss a red flag, where they are going to have the correct clinical knowledge to be diagnosing and managing certain patients. So on to kind of our plan, the Surrey Physio plan, as we move through. So stage one is the stage that if you've been working for us for a while, we think you should have completed. Or if you've just joined us, that we need to get completed as quickly as possible. So first things first is all statutory and mandatory training completed and sent to Lorraine. So that's all your standard basic life support, safeguarding, etc. And then also the additional FCP ones of primary care, personalised care, and the ionising radiation, EIMR. We've got a spreadsheet, so we know pretty much what people have done. There's still some gaps. So I know pretty much everyone got contacted recently about the gaps that they have. I know this is the most boring part of the roadmap, but it is arguably the most important, because if something happens, this is the stuff that we need to turn around and say the guys have done. So if we can all get our statutory and mandatory training done as quickly as possible, then we can get that one ticked off. The other thing that I've asked some people for, and we can get you guys to send across, is any training that you guys have done already that would be at a master's level or level 7, or that would be relevant to primary care. So that I know some of you have MSCs in advanced physio or masters from abroad. That's great. Some of you might have acupuncture modules, some of you might have injection modules, some of you might have done blood test courses, some of you might have done kind of complex assessment modules. Anything that you guys think would be relevant, it would be great for us to know, because then we can kind of keep a database of what's been done so far and some training needs potentially that might be opened up in the future. We're hoping to work more and more with people like Health Education England to provide some funding. So if we identify areas that need to be funded, we can certainly look into that. And it's just good evidence to have on your portfolio as well. And then the final thing that most of you have done, some might not have done if you've joined us recently, is a personal development plan. So if you have a look at the roadmap document, which I'll attach to this file, I think on page 69 is an example personal development plan. So essentially a personal development plan is as it sounds, it's some goals and targets for you guys to write down that we can then work with you over the next year, couple of years, dependent on the time period that you put down. Now, these goals need to be achievable. Obviously, ideally, yes, we'd all like to own Surrey Physio and be Tim Allardyce, but that's not going to happen for everyone. So we need these goals to be manageable goals that your clinical leads can work you on. So you've all worked in FCP for a little bit of time now. You may have identified, oh, I think I need a bit more knowledge on rheumatological conditions. I need a little bit more knowledge on knee special tests. So some simple ones like that we can help you work with through supervision, through kind of free courses that we can find online. And then what I would say is put a couple more complex ones on. So some where you see your career progressing as well. Because as I say, the point of the roadmap isn't just kind of making sure that you're good enough, but also how you see your career progressing if you see yourself staying in primary care as well. And the clinical leads will work with you on these skills. And I think they say write them almost like SMART goals. So have your goal, have your timeline, how you're going to achieve it, and do a little bit of research to help us as to how you can achieve it as well. And these personal development plans can be updated as we move forward and you guys move forward in your career as well. So that's stage one. So I think most of you have done that. If you haven't done that, if we can get that done and sent to your clinical lead as quickly as possible, if you need any help with it, please do let us know. So stage two. So this is the stage that we are currently doing, and I know some emails have been sent out about this already. So and I've put on there, ideally to be completed by the end of October. If you're a new starter, obviously we need to push that date back a little bit longer. But if you guys have been working for us for a while, if we can aim to have this done by the end of October, that would be great. So first things first that we need to do is we need to have 40 patient satisfaction questionnaires filled in. Now, either these can be printed off and filled in by the patient there and then in the clinic, and you can collect your 40 and just have them as hard copies. Or what you can do is there's a link, which I've sent out to my team. We might need to spread this a little bit wider, that you can attach to an AccuRx text and send to your patient. So if you haven't seen them or you want to see them or want to do the test afterwards, you can send them the link. They can fill in the questionnaire online and we'll get your feedback back through a collated database. We've got to have 40 in total. And then what we're doing is we're doing some data analysis on that. We're probably going to take 10 to 15 randomly, do some data analysis, collect an overall score. And then what we'll do with you guys is we'll feed that back, because it's all very well and good having 40 patient satisfaction questionnaires that me, Chris and Dan have seen, but you guys need to know the areas that you can progress on and work on. So if you guys can focus on collating those 40, either paper copies or sending the online link, and we can keep you updated with the online numbers if need be, that would be great. The second thing we need to do, similar to the first one in terms of looking down a survey route, is we need 10 multi-source feedback. So essentially 10 multi-source feedbacks is feedback from 10 colleagues that you work with. Ideally, we need it to be 5 clinical and 5 non-clinical. If you're 6 and 4, I wouldn't worry too much, but if you can try and aim for 5 and 5, that would be brilliant. Again, for this, it ideally needs to be anonymous. So you can't stand over your GP's shoulder and say, come on, doctor, rate me outstanding on all of these. It ideally needs to be anonymous. So again, we have an online link that you can email to the GPs in your practice and ask them to fill it in. That will then send it back to a centralized database. And again, myself, Luke, and the clinical leads will do some data analysis on that and feed back the general themes. Ideally, this wouldn't be done on a paper copy because of the anonymity facts. You want this to be relatively anonymous, just so we get some honest feedback, because from my point of view, good feedback is fantastic, but also some areas to improve on is also good, because I know I'm not perfect in terms of what I do. I'm not a perfect FCP, and the feedback I got gave me some good pointers in terms of things I could do a little bit differently in terms of communication and things like that. And that's the stuff we really want to see, because that's what we can feed back to you and work on. So again, guys, if anyone needs the link to send to the GPs, either ask kind of your clinical lead or ask Luke, and he can send that to you. We can send it out to the GPs, but it's probably better coming from you guys, because as much as we have contact with your GPs, they're probably thinking, who on earth is Will Bateman emailing me with this questionnaire? So if you guys send it to them, we're more likely to get responses. So that's the first two things. Third thing is the notes audit. So I know some people have done this already, sent across your notes and had your notes audit done, but everyone is going to have a notes audit done by the end of October. So you'll be contacted by either myself, Chris, Lockie, Sue Ellen, or Dan, and you'll be asked to send 5 sets of clinical notes across. We've got a marking tool, and we'll mark them against the tool. Again, we're not looking to overly criticize notes. This isn't a test, but again, it's just pointers that we've developed a notes tool that GPs and FCPs seem to like. And it's just making sure we're writing down all the clinical information that we'd need. Let's say, God forbid, a patient did go wrong, and we've got the clinical information down that we know we're safe. And also, a lot of you will work in PCNs where there might be 2 FCPs. If I was, say, working in Alan's PCN, I want to be able to go in, walk in, see the same patient in him and think, okay, I know exactly what Alan's thinking. There's his clinical reasoning. There's his diagnosis. This patient hasn't got better. What's his thinking moving forwards as well? So it's just making sure we're collaboratively working across patients. So if you haven't been contacted about a notes audit, you will be contacted soon. And if you have done your notes audit and haven't heard anything, we're just getting through them. We're doing the marking, and our plan is once an FCP has 40 patient questionnaires, there are 10 multi-source feedbacks, and their notes audit done. What we're going to do is organise a meeting with you, and we'll feed back on the common themes rather than having to have 3 separate meetings about each one. We'll do it all in one go, and then we can go from there. The other thing, and I've got this on the next slide so you can see how to do it, is we need to be regularly doing case reflections. So they don't need to be detailed whatsoever. They can be relatively simple. I'm going to flick to the next slide because I've got the reflections on here. So on one side, I've got case reflections, and on the other side, I've got feedback reflections. So when we have your meeting with you to feedback about your satisfaction questionnaires, just fill in the feedback one. So for the case reflections, what you need to do is a brief description of what happened. So you could copy and paste your subjective notes. That would be the easiest way of doing it, just making sure there's no patient information. So just basically what happened at that occasion. Sometimes it may not necessarily be a case. It might be a discussion you've had with a doctor or with one of us. So just a couple of lines on what the patient was and what happened, what the diagnosis was, and your clinical reasoning behind that. So how did you come to the diagnosis, and what was your working diagnosis? What went well? So just a couple of lines on what you think you did well. So correctly identified red flag symptom in a timely routine, sent to A&E. Perfect. That's what we'd like to see. Or diagnosed an ACL rupture, sent for an MRI, ACL rupture confirmed. Fantastic. That's brilliant. What we also want to see is what can be done better. It's not particularly interesting or useful for us if you send us lots of really, really positive case reflections. We know you guys are good. It's great to see that you are doing well, but what we want to see is those ones that maybe you think, okay, I could have handled this a little bit better. An example of mine recently is I had a lady who was 65-ish, bit of trauma to the hand, and had pain about 3 months later. I x-rayed, there was no fracture, found a little bit of arthritis, so I rehabbed it as an arthritis. looking back on it in reflection, potentially the diagnosis of arthritis didn't particularly fit with her clinical pattern. She came back a couple of months later, no better. So I sent to Hand Clinic. They eventually did an MRI scan, and they found something called Kienbock's disease. It wasn't something I particularly heard of before, but it's basically where you get a degenerative fracture of the lunate bone. I probably, on reflection, jumped on the X-ray findings a little bit too much and rehabbed it as an OA without particularly taking in the clinical picture. I've done a reflection on that. That's a really, really nice one, because the clinical reasoning behind my X-ray and things was sound. So that's what you can put in the what did well. But actually, there were things I definitely could have done better on that case. And those are the ones that we really want to see, because it shows that you're clinically thinking about those cases. A little bit of a conclusion about how did that impact your practice. So I went away, did a bit of research on Kienbock's disease, so I'll be better prepared for next time. And then there's a section where we can add our comments when we discuss those with you. So that's a case reflection. And then what we like to see as well is when we guys do have meetings with you about your feedback on patient satisfaction questionnaires, just a reflection on those results as well, because again, it's good us telling you your data, but it's nice for us just to see that you are reflecting on that and saying, okay, I've scored really highly on my objective examination, but maybe I scored a little bit lower on the patient, didn't feel they were being listened to quite as much. Maybe I need to take a little bit more time on my subjective examination, really listen to the patient and not just dive in so quickly on my objective. It might be a little bit the opposite. They might say subjectively it was really good, but they felt the objective could have been a little bit stronger. So again, reflecting on those and then how that will impact your clinical practice as well would be great to see. So ideally, by the end of October, what we'd like to aim for is to have 5 of those sent to your clinical lead. So interesting cases, and we're going to build on these. So it's going to be 5 over the next 3 months. So start with 5. That would be great. The other thing, and this is just an ongoing thing, you don't need to send this to anyone, is just keep updated a CPD training log. So any CPD that you do, whether that be Tuesday evenings, whether that be something you do off your own back, doing some research, whether that's an official course you go to, just keep a list of what you're doing with a little bit of a very, very small reflection at the end, just how it will impact your clinical practice, e.g. I'll routinely scan for blood tests more, or I'll be more willing to pick up a Kienbock's disease, something like that, just so we can see that you are making an effort to work on your professional development and not just coasting through the role. And as I say, the other thing that will come up is the clinical leads will be having a meeting with you once we've collated your feedback. It will probably be at the end of every month. We'll be sending you an email giving you an update of how you're doing. And if you are lacking behind, we do need to try and get these done. So if you guys can work on that, that would be great. So kind of stage 1 and stage 2, this presentation will be available. So don't worry about remembering this all. Ideally, if we can have that done roughly by the end of October, that would be great. And that will give us, the clinical leads, some time to feed back to you guys as well. So those are the reflection examples. So the guys in Wandsworth and Lambeth, I've sent you all these documents. I don't know whether the other guys have had it soon, but we can forward those emails onto the Croydon, Sutton and North East London teams as well. So the next stage, so this is something that the clinical leads are going to have to work on a little bit more than you guys, but just to keep you in the loop of what we're doing. What we're going to be organising by the end of the year, roughly, dependent on how long it takes, is we're going to organise to come and watch one of your clinics, essentially. We will have to do, during that clinic, 3 patients where we will say to you, this is going to be an observed consultation. We don't want you guys to see it as an exam. We do have certain questions and marking criteria that we are working through. But again, we just want to see how you guys are clinical reasoning, how you're working with patients, your communication style, and then just giving you some pointers of things that you could improve on. Again, we've been doing the FCP role a similar time to you guys, so we'll be getting feedback as well, and we're more than happy for you guys to feed back to us. But what we're going to try and do is we're going to try and come for one whole session, so a 4-hour clinic. And what we'll do is we'll pick 3 patients randomly. It might end up being a really simple knee arthritis. It might end up being an absolute whopper of a complex one. We just don't know. We'll pick it randomly, and then kind of it's up to the gods of the patients, basically. And then what we'll do is we'll fill in the feedback form, and we'll send those across to you with a bit of feedback. And again, if then you guys can do a reflection on that feedback, that would be great. During those observed clinics as well, what we'll also be doing kind of the whole time is just keeping an eye on 2 clinical skills assessments. So one of those is your special testing. I think special testing is something that all physios should do, but I think as an FCP is especially important, because we want to be definitely differentially diagnosing between different pathologies. We want to be, let's say it's a knee, we want to be sure that if it's an ACL, if it's a meniscus, is it a rotator cuff pathology? Is it a frozen shoulder? We want to be seeing those special tests in action regularly with patients, and then we can feedback on that. So again, we'll kind of just be watching, again, not assessing, but just checking that the special tests are being done, and then we'll feedback on any areas where we think, okay, your special testing for the shoulder and the wrist were fantastic, but actually for the ankle could have tested the ligament draws a little bit more. And then again, you guys can go away, reflect, and then we'll kind of see how you're doing. And then the other thing we're keeping an eye on, and I think this is the really key one for FCP, is just keeping an eye on your clinical reasoning and questioning. I think that our clinical reasoning and questioning is really what defines an FCP from a standard senior outpatient physio. So again, we'll just be keeping an eye on the questioning that you're asking patients, that you're making sure that the questioning is guided by your assessment. And again, what we'll probably do at the end of each patient that you see is ask for your diagnosis and just say, how did you get to that diagnosis? What was it you looked at during your assessment that led you to diagnosing that? Obviously, we're well aware we can't diagnose something every time, but we'd like you to have a stab in the dark. We don't mind if it ends up being wrong. We don't mind if we end up disagreeing a little bit. But if you can turn around to us and say, look, I think it's a gastrocnemius strain rather than a soleus strain because of the palpation level, because of this special test, that's what we really want to see. We just want you to be using that clinical reasoning that's a little bit more advanced than we'd expect from someone in a senior physio post. And again, once we've done the session, we'll send across some feedback and just say, great, clinical reasoning was really good. Maybe just look at your clinical reasoning around differentially diagnosing back pain, or look up the most recent research on whether, I think they're saying now 60% of back pain is non-specific. And do you think the clinical reasoning of this diagnosis was good, or do you think it could have been a little bit less specific? So we can feedback on that as well. So we'll organise to come and see you all. And then we'll do feedback with you as well. Whether that's a meeting that we do or whether we just email that across, I'm not 100% sure yet. I think it will depend on time, basically. I'm going to skip to the bottom one because the next one just needs a little bit more explanation. By the end of the year, so between October and December, so that 2 months, another 5 reflections would be great on some cases. So that's going to be roughly once every 2 weeks. So it literally needs to take you 10 minutes. Don't worry too much about it, but one every couple of weeks would be great. And then the next thing you're going to do is, and this is probably one of the bigger things that you guys will have to do, is we're going to ask you to present 3 case-based presentations. So for some of you that may have looked at the roadmap already or had some communication with Sam, this is essentially what they class as the case-based discussion. The case-based discussion is very much designed for someone who works in the practice with another FCP, because they can do a presentation there and then. Obviously, we're aware a lot of us work individually, so we've just had to tweak it slightly to make it more appropriate for us. So what we're going to ask you guys to do is, in one go, so each presentation is going to be 15 minutes with 5 minutes of questions at the end, is present 3 cases. Now, the key point in this is these do not need to be complex cases. I know I'd be the same. If I was going to do a presentation, I'd want to do my really complex diagnostics. I found a really obscure pathology and I'm really pleased with it. Do that as a reflection, because that's really great for us to see. But actually, in terms of the presentation, we want something a lot more basic, because we want that backwards and forwards of questioning. So it's probably best to do a bit of a non-specific shoulder pain, non-specific knee pain, and a back pain, something like that. One where you can show to us, look, this is my clinical reasoning, and we can question, okay, why did you do this test? Because If you've done a really complex one and you found something great, that's brilliant, but actually we can't question you because you've done everything yourself. And the point of the case-based presentation is for you to really show to us that your clinical reasoning is good, and then for us to ask you a few questions about certain areas that the roadmap is looking for. Now, I'm going to come back to the case-based presentation because I've got an example of what we'd like to see at the end of this that I'll just run through. So that will help make a little bit more sense. So that's stage 3 by the end of the year. Obviously, apart from the case-based presentations and the reflections, that's more for us to organise with you. So just expect that over the next coming months that the clinical leads or Dan will probably kind of get to come and visit you for a session. Stage 4, quite simply, so between January and the end of April, we're going to have to do stage 3 again, because what we want to do is at the end of your case-based discussions and your clinical observations is we want to feedback things that we think that there could be some improvement or some research on. And then we want to come back and see you again to see that you've improved essentially, or not necessarily improved, but worked on the areas and that you're growing as an FCP. So we'll do the whole stage again. Every FCP, now this is the bit where we're not quite sure on how we're going to do it yet, is going to have to do an audit or a quality improvement project, either on themselves or on an aspect of how FCP is run. Now we're going to have a bit of a think of how best to do this, because if we worked as independent practitioners, I think this would be really easy because you could audit something within your PCN. But where some of us flip between PCNs, where some of us have multiple FCPs in PCNs, we just need to think of a way how we can run this the best. We might do a referral quality one. We might do a scanning one. We're going to have a bit of a think and get our thinking caps on and think of the best way. But we're not going to do this to next year because obviously you guys have got some stuff to be doing for now. So we'll kind of touch base on this probably in January time, and we'll come up with a bit of a plan. By the end of April, ideally we'd have about 25 reflections. So obviously another 15 from January to the end of April. So I think I've worked it out. It roughly works out as once every 2 weeks. So if you guys can get started on those now, that would be great, rather than having a backlog in April where you're thinking, Christ, I've got 25 reflections to do in a week. These deadlines aren't set in stone. We're not gonna be kind of really pushing you because the deadline for the roadmap has been removed. But personally, I work best to a deadline. I know quite a few people will probably work best for a deadline, and it just means that we can kind of keep on top of things. So if you guys can roughly stick to this, it will make your lives and our lives a lot easier as well. But if there's reasons you can't do it, look, we're not going to be really pushing you. And just by the end of April, if you've sent us an update of your training log, what you've done over the last year, that would be fantastic. So stage 5, end of May 2022. This is again more us. So the supervisor will give you a report. So for your clinical lead will give you a report, and we'll give you some goals to work on over the next year, because we've got to repeat some of this over the next year, and you guys can kind of reflect on those. We'll then have to upload everything to the online portal. So we'll probably send back everything to you that we've collated and added our comments to. And then we'll get that signed off, and that will have to be signed off by the overall supervisors. So that will be either Tim or Ben. They'll sign off the portfolios. And then just as a second line, we're going to have to repeat this again next year. But I think once we've done it once, it's going to be much easier to do next year, because we're going to be knowing what we've got to do. So the roadmap is going to be an ongoing process. We don't have to do everything. It will be more like the patient questionnaires, satisfaction questionnaires that we'll have to do again. But that's in the future. Let's not worry about that for now. So that's kind of our plan for the roadmap. What I thought I'd do is obviously, I guess, the biggest piece of work for you guys individually to do, aside from your case reflections, is going to be your case-based presentations. So I thought what I'd do is I'd just run through a rough plan of what the roadmap says they'd like to see in the presentations. I haven't done a specific case because I think it would be good for you guys to kind of come up with your own cases. Yes, Chris, good idea. Let's just take a pause there. Has anyone got any questions about the stages of the roadmap, what I've just run through? If they're individual questions about how far you are, just leave those, because we can reply to those individually. But if anyone has any general questions, shout now, and then we can help answer those. Perfect. There's no hands up, is there? I can't see anything. Cool. And if you guys do have any questions that crop up afterwards, feel free to message me. I'm more than happy to answer them. I appreciate the roadmap is really confusing. I've probably only just got my head around it, and I've been looking at it for quite a while. So if you guys do have questions, please do ask. So case-based presentation. I've split this into 5 sections. What it would probably be a good idea to do is, when you guys are making your presentations, roughly follow this. All we want is about 5-6 slides. Doesn't need to be particularly complex. And the questions underneath each subheader is the questions that the roadmap want you to answer. So if you guys can answer this in your presentation, fantastic. If you guys don't answer them, this is probably what we're going to be asking you at the end of your presentation. So just giving you guys a heads up, this is the stuff that we need to cover, because this is the stuff we have to tick off on the roadmap. So what I would, as I say, I'd pick a case, and then the first thing that we want to see is your communication and consultation skills. So how do you interact with that patient? So your style of interviewing and communication. So if you guys have a look online, there are different styles of motivational interviewing and communication. And it'd be good to see that you guys said, yep, I use this style of communication with the patient. And were there any challenges with communication, and how did you overcome them? Was there a language barrier? Was there a learning disability barrier? Was there a male to female barrier? Was there a second person in the room? Was there, sometimes there's a bit of a personality clash even. Do you feel there was a little bit of coldness from the patient about your questioning? That'd be good to hear. That'd be great to hear. And how did you overcome those? For example, I asked a female chaperone to come in the room. I use language line. I changed my communication style from direct to indirect. So things like that, how you overcame a challenge of how you interacted with that patient. The next section would be promoting personal, well, I've written that twice, promoting personal and personal health. I'm not quite sure what I was meant to write there, but promoting personal health, we'll go with that. So what other factors did you consider? With us working in primary care, we have to see the big picture. They are not just a knee arthritis. What else can we promote for that patient to change their lifestyle and get better from their injury? So I've put weight, lifestyle, smoking cessation, drug history, alcohol dependence. I know in certain practice, I know where I work over in Battersea, they've now got a life coach within the GP practice. Have they seen the life coach? Are there things that they're working them on? So what other factors did you consider could be kind of influencing that injury? Have they got chronic pain? Have they had a traumatic injury in the past? Have you had a look through their notes and they've been to pain clinic multiple times? Are there psychosocial factors? Lots of different things that you could consider there. And the next one, and I guess for most, this probably isn't going to be particularly relevant. Ethical approach. Was your approach ethical? And just a quick line on how you made sure your approach was ethical. So made sure if they were undressing or changed into shorts, left the room, pulled the curtain around, make sure I offered them a towel, make sure that if there was a kind of a cultural difference, I questioned them about that to make sure that they were happy without a chaperone or to see a male clinician. So just any ethical considerations. Sometimes there'll be none. They'll come in shorts that you're looking at a knee and just put not relevant, but just any that you did take into consider is good to see, just because it shows that you're thinking in that sense. So that's stage one, pretty standard bits. So section 2, working with colleagues. So with this patient, and again, sometimes this will be a no, but did you use any of the other PCN or GP staff, and why? So for example, I mentioned in Battersea, they've got a lifestyle coach. Did you use a social prescriber? Did you speak to a GP about medication? Did you use the pharmacist for medication? So anyone in your direct PCN. So this isn't people you refer exteriorly to. So this isn't single point of access, MSK CATs, people like that. This is people directly in the PCN that you've used. So again, some cases there'll be nothing, but it'd be good to see that there are ones. It could even be spoke to them on the phone, booked them in for a face-to-face with a colleague. Great, brilliant. It's good to see that you're thinking that they need a face-to-face. And then I guess the next section is your subjective examination. So this is where we really get into kind of the clinical reasoning. So one question that we want to see is, what special questioning did you use to rule out differential diagnosis of that patient? So for example, for the knee, you'd probably want to be asking locking and instability. For the back, you'd want to be screening red flags, bladder and bowel. For the shoulder, instability, things like that. So what special questioning did you use to say, okay, I think we're heading down this route? And then what would be nice to see is how did your questioning guide your examination? Probably the easy example is around a frozen shoulder. You can ask them, have you got good movement in your shoulder? Have you noticed a reduction in movement? If they say, no, I've still got full movement, but it's really painful, we're pretty much thinking straight away, I'm pretty sure it's not a frozen shoulder. And you can kind of say that guided my examination. So we just want to see your clinical reasoning behind your questioning, and that you're not just scattergunning questions and scattergunning examinations, basically. So next one is your clinical examination, leads on quite nicely from the next one. So why did you choose to do whatever in your examination? So this kind of leads on from the previous questioning. So if your questioning has guided your examination, why did you then choose to do a certain test or a certain movement? So let's again take the frozen shoulder, for example. Let's say they haven't lost movement, but they say, oh, it sometimes feel a little bit stiff. You may have tested passive external rotation straight away. They've got full passive external rotation, and you've pretty much ruled out a frozen shoulder. And you can say, the reason I did that is because they did mention some stiffness and I wanted to rule out that pathology. Great, that's exactly what we want to see. Nice and simple diagnosis has ruled out something nice and quickly. And then you can kind of delve a little bit more into the stuff that you did do and why you did it. And that's where we really want to see your clinical reasoning. So I was testing rotator cuff strength because they had a fall onto an outstretched arm, or they were at an age where they were struggling to lift their arm, but passively they had good movement. So again, why did you choose to do certain tests, certain examinations, and not that just you were doing active range of movement, passive range of movement, special tests with no real specificity to those tests? We want to see why you're doing them. And then just on reflection, looking back on the case, maybe once you came to the diagnosis, is there anything you'd wish you checked? We thought, oh, I should have checked that. Example, this is more of an observation tool, but when Chris first started, he came to observe one of my clinics on just to see how it works. I think it was a wrist patient. I can't remember which way around it was, but I didn't test either Finkelstein's or I didn't test for carpal tunnel syndrome. And afterwards, Chris said, oh, well, how come you didn't test that? And on reflection, I thought I probably should have done. I probably should have ruled out that differential diagnosis. So just anything, when you look back on your case and you're doing this presentation, you think, oh, actually, I probably could have tested that just to rule that out. That's really great to see because it shows that you're doing that reflection. The next one, the big one, explain your clinical reasoning for your diagnosis. Pretty standard. What was your diagnosis and what bits of your subjective and clinical examination led you to that diagnosis and why? So as I say, we really want to see your clinical reasoning as to why you got to that diagnosis, basically. That's kind of a running theme, as I say, through all the different things. Section 4, again, similar. So leads on in terms of what we do in a clinical examination. Explain your clinical reasoning for your pathway, management, or exercises. So why did you prescribe loading exercises for a rotator cuff pathology? And you can turn around and say, look, the research shows that loading-based exercises has a better outcome than simple passive stretching or range of movement stretching for the shoulder. Why did you do VMO work for medial meniscal pathology? And again, you can say research shows. Also, why did you choose a certain pathway? You may have referred that patient to physio. Why did you choose physio over self-management? You may have referred for an injection. Why did you refer for an injection instead of physio? So again, it's just looking at your clinical reasoning as to the pathway that you chose. So just explaining what you've done and then explaining why. And I think that's the really important question is all of this. It's that why afterwards. Why did you do something? That's what we really need to see. Next one down, less relevant, won't be relevant for all cases, prescribing pharmacotherapy and treatment. So if you were to prescribe pain medication for this case, what would you prescribe? So would you prescribe naproxen because it was an anti-inflammatory? Would you prescribe amitriptyline because it was more of a nerve-based pathology? Would you prescribe diazepam because it's an acute back pain, muscular back pain? So just you don't have to have prescribed it, but just if you were, what would you have used? And then any alternative treatment that you think could have been beneficial. And it doesn't have to be available to you. If it's a tendinitis, would you have considered shockwave therapy? If it was a shoulder pain, would you have considered an injection, even if you can't necessarily refer for an injection? Would you have considered a dietitian? Would you have considered a GP opinion? So just anything else that you think, oh, that could have been looked at. Again, most cases it's going to be no. You would have done everything yourself, but it's good just to see you thinking through that. Next one's a bit of a tricky one, and I think it's a bit of a hard one to answer. Leadership, management, and organisation. So the first question is, how did you organise this appointment to make sure it ran to time? If you needed to do a referral form, did you make it a 15-minute appointment? If you needed to go and speak to a GP, did you do that within the appointment time? Did the appointment run to time? And the strategies that you used to make that happen? That's probably going to be quite a repetitive one from each patient, because your time management will be pretty good. But again, it's just good to see that you're managing that. And again, for some of these, this will be no, but did you just display any leadership skills in managing this case? So I would say leadership skills are going to speak to a GP. You've taken your onus of your leadership to go and speak to that. Did you speak to a colleague? Did you speak to one of your clinical leads? Again, I'd say that shows certain leadership skills, because you're leading that patient's management. It's not a case of leading a team. It's not a case of leading a large team, but just showing that you're leading the management of that case, basically. Did you call up A&E because it was a cauda equina? Did you call up the orthopedic registrar to say, is this appropriate? Things like that would be great to see. Again, most cases it's going to be no, but just a line on that, if you did do it, would be good. And then the final section, section 5, and this is more about your CPD moving forward. So first one is education and development. So following this case, what have you done to enhance your education and development in this area? So if some of these, there won't be too much, because you did it well. But if there was one where you thought, okay, I could have done this a little bit better, or I could have tested this special test, what have you done post that appointment to work on it? So this might be something like you've done a case reflection and you've looked up a little bit of research. You've researched an online course. You've read an online article about Kienbock's disease. I keep saying that one, but just because it's in the front of my mind. And that would be good to see. Some cases it will be nothing, but again, it would be good to see if you have done that. And then a bit of a generalized question. What else are you doing to enhance your education as an FCP? So this isn't necessarily a question about this case, but this is more about themes you've noticed. Have you noticed you're a little bit weaker when it comes to reading blood test results? Have you noticed that lots of your hip pathologies tend to come back because they're not getting better? Have you noticed any trends, and what are you doing to enhance those? And then the last one, research and evidence-based practice, because all our practice should be evidence-based. This kind of links into your explain your clinical reasoning for your management, because it would be good to mention some papers there. But summarize 2 articles you use for your clinical reasoning in your case. So I mentioned an article that shows that load-based therapy is good for the shoulder, an article that shows that eccentric exercise is really good for the Achilles, an article that shows that shockwave therapy is good for lateral epicondylitis, a paper that shows that actually self-management is just as good as an injection after 3 months for frozen shoulder, things like that, just to show that you are going away and working on those things, basically. That's it. That's the presentation done. I will share this with everyone. Let me just come back to Zoom, and then I will answer any questions. Perfect. Back to the full screen. So I'll send out that presentation. Don't worry, you don't have to have remembered it all, and I'll share it with everyone else as well. And we'll share this recording with everyone, so they can fill in with everything. But it was just so you guys knew what our plan was and knew what we've got to get done by April 2020. Well, roughly April 2022. As I say, we don't want this to just seem an arduous task that we've all got to get to. It's good CPD for you guys. It's good learning for us. It's good learning for you, because we can feed back on cases and things like that. So if you do have any questions, please do ask them now.
Brilliant job, Will.
I bored everyone to death.
I think you must have covered it all. Well done. Absolutely great work. And Chris supporting as well. Thanks, you guys. Superb.
Great. So I'll Tim, do you mind sending this recording out just to the London FCP teams?
Yeah.
And then I'll pop the presentation on the WhatsApp group as well. And as I say, if you guys do have any questions that you'd rather just ask individually, because it's more about your individual kind of roadmap progress, you're probably just best to ask your clinical lead in your area, because they'll have your updated.
But if you go around again, you can buy the next one if you don't know.
They'll have your updated progress of where you are. If you have any general questions about the roadmap, I've spent hours reading it and it's incredibly boring, but ask me, because I hopefully will have the answer, or Tim or Ben, because they've done the course as well. But there's going to be questions that crop up. There's going to be changes, I'm sure. As I say, things like the audit, we've still got to work on. So we'll keep you guys updated as much as we can, but hopefully that just gives you a bit of an insight as the plan moving forward. Cool.
Yeah, well, I think what you said there about the case-based presentation, why it's so important to keep a simple patient there, is because of all of that other detail that you've got to go through. Keeping that patient as simple one as possible, that's quite, you don't want a complicated back, neck, shoulder, knee kind of patient. You want to keep it just as simple as possible, because of all that extra detail that you've got to go into.
100%. Yeah, there's a relative amount to get to in a 15-minute presentation. And as I say, what we really want to see is your clinical reasoning and things around it, not just that you've done really well and found something interesting. That's better on a reflection, as I said. It's great to see, and it's fantastic that you guys are doing that, but it just wouldn't make the case-based presentation particularly good, and we want it to be as good for you guys as possible. So yeah, as Chris said, keep it simple, stupid. That's the saying, isn't it? Cool, lovely stuff, guys. Well, I will let you all crack on with your Tuesday evening. We'll get the presentation shared, and as I say, any questions, give us a shout.
Great job. Thanks, Will. Thanks,
Cool.
Chris.
See you later, guys.